This is Category 3 SOT, Part 2. It would be. So these are just some pictures illustrating that we have, let's say, in the left-hand picture, we have tippage of L5 on the left, aka closed wedge left, so the left styloid's painful. And on the right, we have closed wedge on the right, so the right styloid's more painful. And the styloid needs to be palpated just behind the jaw, right up against the bottom of the ear, right in front of the mastoid. There's a groove there in between your mastoid and your jaw, way in there. Dig in with your index fingers. You can do it on your own body right now and see if one side's more painful. And here we have a PL, it happens to be PLI on the left. So the atlas, since we have spinous left, the posterior arch of atlas on the left will be way more painful than on the right, and it'll be super tight. And if you do a little bit Mopal, it'll feel like you have a posterior left atlas in Mopal. That's what it'll feel like. And on the right, we have the opposite. So there's your indicators for atlas, for spinous. And this is a picture of what's called the Lovett Brother system or Lovett Brother ideas. The Lovett Brother idea is that the sacrum and the occiput work as a team, and L5 and C1 work as a team, and L4 and C2, and L3 and C3. And what I mean by working as a team is most of the time, if there is a sacral subluxation, occiput will compensate, and it will compensate in the mirror image of the sacral subluxation. So for instance, if a sacrum was posterior on the right, occiput would probably be anterior on the right. If sacrum was a base posterior, you'd have an anterior occipital base. If you had a PR L5 with the spinous to the right, the body to the left, you'd probably find a posterior atlas on the right. You'd find the opposite rotation. And the reason for this, and this is partly assumption, but very much based on what we know about the architecture of the nervous system, it seems that the vestibular mechanism has a very high priority, protection-wise or survival-wise. And the body has built-in mechanisms through the traps and SCM muscles and the scalenes and other muscles that are capable of changing head position and changing cervical positions. It has a built-in ability to balance the top when the bottom is out of whack. So that's the way the Lovett Brother system seems to work, and the mechanism is probably through long propiospinal tracts and also direct detection by the vestibular mechanism of a problem at the other end of the patient, other end of the patient's body. So in SOT, it's not called the Lovett Brother system, it's called the R+C factors. But that's very proprietary language, and I'd rather we just call it the Lovett Brother system. And this was taken from an article in the Journal of the Canadian Chiropractic Association, written by Charles Blum He is or was the first president of one of the SOT organizations. And what this picture shows is we have inferior tippage of all the lumbars on the left side. And what you'll get in the neck is you'll get palpatory pain at the left styloid. And that coincides with tippage of L5 on the left. And the C2 spinous process, it'll feel like it's PL when you palpate the spinuses. It'll feel like body right all the way down, as if the patient had an overcompensated cervical syndrome or a right first rib. The C2, C3, C4, and C5 spinuses will all be more painful on the tip down lumbar side. So C5 corresponds to L1, C4 corresponds to L2, C3 to L3, C2 to L4, and there is no spinous per se of atlas. What we have is another area that also begins with an S called the styloid. And the reasons you get that palpatory pain on the same side as lumbar tippage at the associated Lovett Brother is due to muscle effort on that side of the body to untip the neck. So what those muscles are doing is they're purposely sort of creating right tippage in the cervicals by lifting up very strongly on the left. So you'll get palpatory pain at the styloid or the spinous on the side of tippage of the associated Lovett Brother lumbar. On the right side of this, we have spinous right. In other words, we have rotational problem of all of the lumbars. And actually, that rotational problem is also drawn in the lumbars on the left. We have a PR, all the lumbars. And this is only for illustration purposes. You wouldn't necessarily find this on a patient unless they were severely antalgic. So you might see this on a category 3. The L5 corresponds to the styloid or atlas. You see, atlas doesn't have a spinous process. So the muscles that would normally attach to the spinous of atlas, if it had one, are attached to the styloid. That's why we use the styloid on the other part of this picture to tell us tippage. But atlas does have a posterior transverse process, a posterior aspect of the transverse process, which I think for your palpation purposes, you should realize is really sort of the posterior arch. So if you palpate the posterior arch of atlas on this patient, you're palpating, it'll be painful on the right because the patient has spinous right L5. Now C2, 3, 4, and 5 don't have a posterior arch, but they have an LPJ. So if you palpate over the LPJ, which the SOT book refers to as the posterior aspect of the transverse process, I think we're more used to palpating over LPJs. The LPJ will be painful on the side of its associated Lovett Brother lumbar spinous rotation. So we have drawn here PR, all of the lumbars. So we have palpatory pain over the posterior arch of atlas and the LPJs of C2, 3, 4, and 5 on the right, which is the side of spinous rotation. Now, when you get a category 3 patient, they're not going to have all of these involved most of the time. They will have one major one, maybe two. So we can palpate the cervical spine on someone with a lumbar subluxation or lumbar distortion, which sometimes doesn't need to be adjusted. But in a category 3, we're going to assume the lumbar spine does need to be adjusted because that lumbar, let's say L5, is sitting on top of a real dysfunctional disc. and you're not going to normalize disc function without adjusting the segment above it, and you won't be able to adjust the segment above it very easily unless you've already dealt with the disc dysfunction, which we did previously with our traction procedures. We did the cough test to determine SB plus or minus, and then we tractioned out the lumbar spine, usually with the high blocks in the SB plus position, while we pressed P to A and S to I on the sacral apex while the patient pulled up and held the inhalation. This is manual traction. So we're looking at this Lovett Brother relationship after we've done our traction, because getting ready to adjust. This was a research paper presented at ACC RAC showing that lower cervical adjusting had an effect on muscle tone of the lumbar spine. These people who did this are not all that familiar with SOT necessarily, but it was showing that the lumbars and the dorsals do have some sort of a reciprocal relationship. What they used was a tissue compliance meter, a device that you press into the tissue that shows how much force it takes to push in the tissue, and it actually measures how tight the muscles are. So this was direct assessment. This was an article by Charles Blum from a paper that I just showed you. He took patients from his office, and they had specific cervical reflex point pain, and then he adjusted the associated lumbar in the direction indicated by what was painful in the cervicals, and got pretty good results. This is a tissue compliance meter, and there's all different kinds of heads you can put on that. This is a pretty big one, so it would show tissue compliance of a large muscle like quadriceps, glutes, hamstrings, maybe QL, maybe traps, and it actually measures how much force are you using before the tissue sort of gives way. So there's a way of adjusting in SOT called orthopedic blocking. And orthopedic blocking means that you're going to use one block and a sustained doctor contact that's sort of a sustained tissue pull. You're not going to use a thrust because you're dealing with a really in-pain patient here, although side posture is not contraindicated on the vast majority of Category 3 patients. But you do have an alternative. You have this orthopedic blocking adjustment that you can do, which combines a unique block placement with a sustained tissue pull that doesn't bring the joint to tension, and there's also no thrust. So for lumbar rotation, let's say you have lateral cervical transverse process sensitivity. The spinous has gone to the side of the painful transverse, or LPJ, as I mentioned earlier. You put a block underneath the opposite side of the pelvis. This writer, Dr. Blum, puts it between the ASIS and the greater trochanter. In other words, he jacks up the other side of the pelvis on the prone patient. Then you put pressure on the, if the spinous has gone to the right, let's say, we put pressure on the right spinous with our thumb or the heel of our hand or with some part of your hand, and you just hold it there. And I would do a good tissue pull and really put quite a bit of force into that sustained contact. I would have the patient pull up on the table to create some traction. The block underneath the other side of the patient, and you're going to get a video on this. It's really way easier than it sounds when I'm describing it. Sort of increases your force. It pushes the patient more into your hand. And that's for the rotational part. If there's also tippage or inferiority, because you have the spinous process painful or the styloid. He puts the patient prone on the blocks under both ASISs, which is okay. I usually just use one block under the opposite ASIS. And we hold a sustained I to S tissue pull over the inferior lumbar, which is indicated by whichever cervical has palpatory pain, as if to decompress and lift the vertebra. So there's different SOTers do this in different ways, and I think it's because Dr. Desjarnette taught all different ways to do this, and he changed his methods over the years. So depending on when you went through seminars with him, or when you learned SOT, you learned different methods. So we've been doing it a little bit differently in our labs. The important point is that you do lift I to S with a sustained tissue pull. And I sort of look at this like some of you had an experience maybe in full spine 3 where you thrust it on an area maybe 2 or 3 times, and we said, you know, let's recheck, see if motion is any better. And it was, even though you didn't get that very satisfactory audible that you were most concerned with. This is the same idea. You're just putting a sustained contact in. So it's a really simple idea. And since you're using either one block for the lumbar rotation and either 1 or 2 blocks for the lumbar inferiority, it's a special way to block. And the idea is to enable the patient to walk straighter, and that's called orthopedics. So we call it orthopedic blocking. That's probably not the best title. So here's an example of lifting the inferiority. The way I do it, I teach it in lab, is I put the opposite block in underneath the ASIS facing down. Here we have tippage on the right of L5. So my indicator would have been styloid pain on the right. And you know, you can have any patient where you think they have a lumbar, they need a lumbar adjusted. You go up to the neck and get the listing. It only takes a second of accurate palpation. Ask them which styloid hurts. That's a closed wedge L5 sacrum on the right. And then put them in side posture and do a strong I to S thrust over the ipsilateral mammillary or TP on the right, and that thing moves on the setup. This is the fastest method of lumbar analysis that I'm aware of. This and probably activator isolation tests. But I use this with side posture adjusting, and it works great. So the patient in this illustration has the listing PLS. So they have tippage on the right, and traditionally we lift the tippage first. And I don't even know if you need to do that. I want you to maintain your contact, repeat your contacts until your cervical indicator decreases and ideally disappears. That tells you that there's no need for the cervical musculature to compensate anymore. Now, depending on how long the patient has had this, it might take a while. But this is certainly a safe and very effective and very rewarding alternative to a side posture or maybe a drop table move. You might wonder, can you use this analysis and do a drop table move? You can, but I'm not in favor of prone drop table with a block underneath the patient. They usually scream in pain. So if you're going to do that, use a very light drop and, you know, don't thrust too hard. There's also a blurb down here, right foot to the butt, left foot to the butt. Don't worry about that for now. I'm not sure that's all that's necessary. All that is necessary. I think people added in a lot of complications over the years, and somehow I got caught up with teaching all the complications. The most important thing here is even if you don't use a block, hold a sustained contact over the closed wedge that you see on the left side of the thing, of the picture here, and then hold a sustained contact over the left spinous. Don't try to do both at the same time, although it might work. Okay? The other thing you can do is just put the patient in side posture and just hold a sustained contact without actually thrusting. The muscles of the body may adjust the patient. So this is a picture of SB plus blocking. On the left side of this picture, we've just finished tractioning the disc. We go up and we determine that the patient has the listing PRS. So we lift the tippage first. So we work on the left and we hold I to S, and I have the right block in. And then we go over to the right side and we push the spinous over. We always lift the tippage first. And again, I'm not really sure you need to do it that way. It's just the way that we've always taught it. And when you push the spinous over, you have the left block in. I can see the rationale of putting the left block in when you push the spinous over. It gives you more relative rotation. Okay? You get something to push against. With lifting the tippage, I can see the rationale of using 2 high blocks, because that'll sort of traction the sacrum and the pelvis away from L5. So I think I'm going to start teaching it with both high blocks for the lifting the tippage part in the future. Yeah, I think that's a good idea. And so what's being shown here is the patient is on the blocks. I think I took this picture at home because I think I recognized that piece of furniture. I don't remember where this was. And what I'm doing is I'm holding the contact as I monitor the pain at the other end. No, that's not my table. I stole this off the internet. I don't know who the doctor is there. And I don't have a watch band with a silver bracelet. So this is sort of what it looks like. It's not very exciting. Okay, you're not going to get a huge audible with a bolt of lightning flying out of the patient's low back. But it's very effective, way more than I ever expected. And so I drew this out a long time ago, illustrating that, where you can see that, let's start with L5. We have tippage on the right. Okay, so the right styloid will be painful. Okay, and then we have spinous left, L5, so the left posterior arch of C1 will be painful. And then I did a similar thing with L4. Also shown in this picture is a skill that I haven't really spent a lot of time teaching in lab recently. But it's a good skill, and it's called gluteal fibers, and they're just like trap fibers. There are 7 of them, but you don't use a chart. The numbers start just lateral to the PSIS, and they go 5, 4, 3, 2, 1, corresponding to L5, 4, 3, 2, and 1, and then we have the 12th and the 11th dorsal. There's 7 of those fibers. They're about an inch apart between the PSIS and the greater trochanter. And we palpate them about 1 inch inferior to the iliac crest. They will be tight and painful at the level of the associated lumbar subluxation. Now, it seemed to me when I first started to palpate them that the fiber was worse on the side of body rotation of the lumbar. I have since realized that that's not always the case, so don't pay any attention to that. Use the gluteal fiber as an indicator regarding which lumbar is most distorted. So if my gluteal fiber 5 on the right was way more painful and more palpable than 4 on the left, I go with L5. And it would tell me I need to adjust L5. And then I would go up and get the exact listing with the cervicals, because I think they're way better at giving you a listing than the gluteal fibers are. The gluteal fibers were developed not by Desjarnette, but by David Denton, an SOT chiropractor who used to practice in California. I think he's still in practice up in Washington or Oregon somewhere. A very brilliant SOT chiropractor. And him and Desjardins liked each other. They got along really well. And so eventually the gluteal fibers ended up in the SOT manuals that were printed by Sorcy. They didn't end up in Desjardins' book because he didn't come up with them. Dave Denton did. And he found them in his office. It was just something he noticed about trigger points. So the gluteal fibers can give you the side of body rotation, but they don't always. But they certainly give you the level of lumbar involvement. And some of you are going to say, well, what if they have 6 lumbars? And that one, I don't have a definitive answer for you. I haven't had many patients with 6 lumbars. I haven't had very many at all, to tell you the truth. You're going to have to play that by ear and see which is most fixated, the 6th or the 5th. And is L6 acting like part of the sacrum, or is it acting like a lumbar? I think it's going to vary from patient to patient. There probably are people who have 6 lumbar gluteal fibers where they really have an independent L6, but I think that's going to vary from patient to patient. So take other information into consideration. The cervical palpation, however, gives you a good indicator of the listing. Now, we don't have a cervical for L6. People who have 6 lumbars don't necessarily have 8 dorsals. I mean, eight cervicals, you understand. So, do the best you can, take everything into consideration. So I think in the 80s, in 1980 or 81, this book appeared in print, Manual Medicine Diagnostics, written by these 2 Swiss medical researchers. And what these guys did is they had volunteers have their facet joints injected with saline solution. And of course, if you pump salt water into a facet joint, it's going to swell up because the body's going to want to dilute the salt. And when it swells up, trigger points appear all over the body. And I mean all over the body, even if only one facet joint was swollen. And they noticed that, and you sort of have to look closely here, what they did is they found L5, 4, 3, 2, and 1, T12 and T11, in the exact same location that Dr. Denton had found in his office through simple palpation. But this became the definitive go-to source for verification that what we find in our offices, you can find with invasive methods in a laboratory. I don't know how you get people to volunteer for facet injections. I assume they were either medical students or prisoners. Who knows? Maybe they were students who needed a lot of extra credit. We can't do that at Life because I can't give saltwater injections, but I'd probably have a couple of takers. But they also found trigger points in other locations that that Dave Denton had not previously found. And the important ones are in yellow here. I'm sorry, not in yellow, in white, S1, 2, and 3. And if you palpate just medial to the SI joint at the S1, 2, and 3 levels, you might feel a tight, what feels like a mini tendon. You know what that is? That's a leftover sacral segmental subluxation from childhood. Because in childhood, the sacral segments can rotate and go superior or inferior. But by the time you're like 20, they've all sort of unified. All the discs have taken on so much calcium, the sacrum's acting more like one bone. But we often use those sacral gluteal fibers as a segmental contact point to adjust an S2 or S3 or S1 posteriority or inferiority or even superiority. So that was an unexpected finding. And this book is still in print. It wasn't in print for a long time, and the value of it went up to like $300, and I happen to have a copy. I bought it when it came out. And all the SOTers went absolutely crazy when they saw this because it verified this chiropractor. This is just showing that you have to be specific when you palpate the cervical area. So I'm showing the styloid pain indicates listing or inferiority, tippage of L5, and the C1 transverse process pain indicates that that's the side that L5 spinous has moved to. So in this case, that's the left side of the patient. We'd have PL if it was more painful on that side. This is just a little bit of research I found on propriospinal tracts to support the Lovett Brother idea. And they found that these long propriospinal neurons at C1 and C2 go all the way down to L5 and S1 segments in the spinal cord of a rat. And a rat is a mammal, so chances are it's the same with us. Now and then you'll get, let's say, a chronic lumbar, and you'll adjust it. And I had a patient like this. This is a case of somebody who, an 82-year-old female, she had gallbladder surgery. To make a long story short, she went to this chiropractor finally, and she had all sorts of listings, and she had what's called an occipital fiber, which I'll get into in category 1. An occipital fiber, we palpate on the back of the head, and it might be a visceral issue. And it turned out this lady actually had this occipital fiber 4, which was there due to, let's see, it was ovarian cancer. And, the adjustments helped, but nothing ever lasted, and this poor writer was just so upset because nothing was helping, and he seemed to be close to the problem, but there happened to be female cancer issues with the patient. So keep that in mind. Sometimes when you're not getting results, it could be a visceral issue that you're not taking into consideration. And I had a patient that I saw this guy the entire time I was in practice, just about. He would come in maybe once every 2 months. He had some low back pain. We chalked it up to degeneration in his low back, which he did have on film. And he had been in the Army, and he was a paratrooper, and he had some rough landings. So I figured that's what it is. Turns out he was much later on. He was been under my care for years. He was diagnosed with prostate cancer, and they removed his prostate surgically. Well, let me tell you, the degree of his low back pain went down to maybe 10%. And he only came in maybe twice a year after that because he was feeling so much better. It turned out he always had this. And there was a visceral issue the entire time, and I just never took it into consideration, so you should. And this is from Dr. DeJarnette. He wrote a book in 1962 all about sciatica, and he's quoted here, "In my early days, a learned college professor stated, 'Watch out for the female, especially if she's over 50. If she has a left sciatica you can't get rid of, malignancy, female organs.'" And evidently he had seen it so many times because by 1962, DeJarnette had been in practice for going on 40 years, and he was really a smart man, and he kept really good records. And he looked at all sorts of stuff all the time, way more than the typical chiropractor. Don't forget he was also an osteopath, and back then he had a very holistic knowledge of the human body. So keep that in mind. Don't forget. Okay. This is a picture of me doing a SOT style side posture. Notice that the patient has his head supported. Now for super duper extra credit, tell me the doctor that I'm adjusting here. This is going to be really hard for all of you because he no longer teaches at Life College. He hasn't taught at Life College since any of you have been there. He now teaches at Palmer, Florida. If you can tell me the name of this doctor, I'll give you a point or two extra credit. He's an excellent chiropractor and a very good friend of mine. And what I'm doing here is a mammillary push, and I'm doing a Nelson DeCamp fingertip push. You can't see it, and I need a better picture, but this is a special type of setup. It's called a split leg maneuver, and the patient's top leg, this would be his left leg in this picture, I have actually stepped between his legs, and my outside leg is supporting the back of his knee, and I'm bringing his knee up towards his head. And what this does is it tractions out the low back very effectively. And then I do a body drop through the L5 mammillary, and boy, does that thing move with ease. When I learned how to do this side posture, I started doing side posture on everything this way because it's just easier. It doesn't stress the rotational tension. It stresses the long axis tension. So I like it better than a regular side posture for me. And I like side posture as a patient. I don't mind being adjusted side posture by anybody if they know what they're doing. I respond very well to a Gonstead side posture, but I also respond well to this one also. So I'd show you how to do it. Now, the reason I brought this up is because there's some controversy among some chiropractors. Some of you guys wouldn't do a side posture if your life depended on it and it would help the patient. And what's happened is you've sort of lost your feeling that you'll ever get any good at it. Or maybe you were injured with a side posture adjustment, so you think it's just not safe. That's not true. Side posture is almost always safe, even when done badly. It's hard to injure someone in chiropractic. It can be done, and it has been done, but it's not easy to do. But there may be an absolute contraindication to side posture, a chiropractic indicator of it. We know there's absolute contraindications to side posture adjusting. Patient has bone cancer. They have cauda equina. You know, a red flag. And there's also some contraindications too. Sometimes you don't want to do a pull, you want to do a push, and vice versa. But this is when the patient has no palpable cervical pain. You're trying to find the listing, and you go up to the neck, and they are a category 3. They've got a lot of low back pain, and you don't find a listing. That's about the worst possible indicator. If you're going to do side posture, be very, very, very careful. Don't do a push. Do a pull. It's safer. But what if the cervicals say they have spinous left and spinous right? What if both styloids are super painful? Well, you can't have spinous left and spinous right, or inferiority on both sides. You can't have a closed wedge on both sides. The cervicals are giving you some impossible information. What this tells you is that the patient's having a hard time compensating for the low back. If they have extreme atrophy of the muscles of the lower extremity, this has been going on a long time. You better be really careful. Maybe you tried step out, turn out, and you noticed that the muscle tone on the sciatic leg is missing. That's atrophy. Okay? Be careful of that patient. Or anything else that you notice about the patient where you just get this feeling side posture may be too much for the patient. That's when the orthopedic blocking is indicated. That's when you can still adjust the patient, but we would use orthopedic blocking. Okay? And then finally, there is a cranial component. There's a compensatory change in cranial venous drainage, and it might not be compensatory. It might be primary, but I think it's usually compensatory, especially getting drainage out of the superior sagittal sinus, which I'll show you in a second. And what you get is the homunculus, is the picture of the individual on the surface of their brain. I'll show you to in a second. And look at where the lumbar spine is on that homunculus, right in between number 2 and number 3 in this picture here. So, wow. Where that patient's butt is It looks like there's no head. The vast majority of the surface of the cortex is hand and face. The tongue gets a big space, actually, and that's probably because what we do with our hands and our faces is much more complex neurologically than what we do with any other part of our body. The rest of our body, everything within the trunk and the lower extremity, is old, very old. Matter of fact, if you look in Kandel and Schwartz, sort of an encyclopedia of functional neurology, it shows you that the neurology that a fish uses to swim is identical to the reflexes that we use to walk. There is no difference whatsoever. So every mammal uses, and even a fish isn't even a mammal, pretty much every animal uses the same neurology, unless they're very primitive, to locomote. But what we can do with our faces, we can speak 10,000 different languages. We can probably make 10,000 different expressions. We can taste, we can see, we can smell, we can hear. There's a lot of neurology going on in the head, but a lot of facial expressions. And we have all these little tiny muscles where we can just emote dramatically. And the tongue can be adapted to speak any language. The hand is what we use to manipulate the world, not just patients. But we manipulate the entire world now with our hands. Okay? Our trunk, our lower extremity, our arm, relatively less important. All the arm does is deliver the hand to the world. What the face does is it communicates the world to the rest of the body. So look at where the low back is. It's right at the joint between the two cortical hemispheres. And right above that joint is a superior sagittal dural sinus. Okay, it's illustrated in these pictures. It's full of cerebrospinal fluid and venous blood that needs to drain back out of the head and get recirculated. Okay, so we help pump that fluid back out of the superior sagittal sinus by doing a procedure called basic 3 cranial. Okay. So we pull the sagittal suture apart, starting right just posterior to the bregma. And the bregma is found when the patient puts the heel of their hand on the bridge of their nose and they lie their finger down, their middle finger down on top of their head. The tip of that finger will reach their bregma. So you put your thumbs right behind the bregma, move your thumbs apart maybe an inch or so, place your 3 middle fingers about 1.5 inches above the ears so that your 3 middle fingers are on the parietal bones, the same bone that your thumbs are on. Then pull your thumbs apart and lift I to S with your 3 middle fingers. This is the last procedure done on a Category 3 visit. It's the cherry on top of the sundae. What's a sundae without whipped cream and a cherry? And boy, do I miss... God, there's a frozen custard place in Kennesaw. I haven't been there so long, I forgot the name of it. Starts with a C. It's the best. I miss that place. I can't go there now because of this darn pandemic. But it's used at the end of the Category 3 visit. Carvers or something like that. This reduces pressure in the superior sagittal sinus, hopefully pumping some of that CSF out. And right underneath that superior sagittal sinus is where the low back homunculus is. So it desensitizes the low back homunculus, and I am here to tell you that this really works. When I first learned it, I just went, oh, come on, give me a break. It really does seem to be important. In this left-handed picture, you can see how far my fingertips are above the ear. You need to give some space because you don't want to be on the temporal bone, which is the bone that the ear is attached to. You want to be on the bone above it, and that's the parietal. And so you want to lift those parietals up when you separate the sagittal suture, because if you don't, you'll jam the parietal bone down, and it'll jam down inside the temporal bone, which is something you don't want to do. Okay? So, and that's basic 3.